I think we should get started. Good afternoon, everyone. Welcome to the Winter 2023 Breast Community of Interest meeting. Thank you so much for joining us today. My name is Jessie Wu. I'm a breast pathologist based at St. Michael's Hospital and here in Toronto, and I'm also the host for this meeting. We have a very exciting program for you today. We're going to start the meeting with a lecture from Dr. Anne Grabenstetter from Memorial Sloan-Kettering, followed by a question and answer session. And then we'll have our presentations of interesting cases afterwards. In our last meeting, Dr. Anna Marie Mulligan talked about the common problems encountered in breast consultation service. So we're kind of continuing along similar themes today. We're here to learn about the management of high-risk breast lesions, where many controversies still exist. And it's a real pleasure introducing Dr. Anne Grabenstetter. Dr. Grabenstetter received her medical degree from Northeast Ohio Medical School, followed by residency at Rutgers in New Jersey. She had fellowship training in both oncologic surgical pathology and breast pathology at Memorial Sloan-Kettering, and she's currently an assistant attending physician at MSK. And while doing predominantly clinical work, Dr. Grabenstetter still managed to have a very impressive research output. Her research interest is mainly on establishing firm, reproducible diagnostic criteria for common high-risk diseases and kind of examining their outcomes to hopefully eliminate the need for unnecessary and invasive procedures. So something that has very practical, direct impact on patient care. We're so honored to have her here with us today. So please join me in welcoming Dr. Anna Grabenstetter.
Okay. Good afternoon, everybody. Thanks for having me. This talk is going to focus mainly on management recommendations for high-risk lesions. I'm only going to touch briefly on the morphology of some of these entities, but it's mostly going to be data on high-risk lesions. So let's get started. Optimal management of so-called high-risk lesions found at core biopsy is controversial, as illustrated in this study. The authors surveyed breast imagers in 41 academic institutions across the U.S. on how they manage high-risk lesions. The authors distributed a 9-question survey. Questions 2 to 8 asked about management recommendations typically given when a core biopsy yields various high-risk lesions, including those listed here. The last question asked whether their colleagues at their institution typically give the same recommendation. While the majority recommended excision for ADH and atypical papilloma, 95% for both, for the remaining, the recommendation for excision ranged from 39 to 76%. Notably, 90% of the institutions reported that management recommendations are consistent among members of their departments. 7 institutions submitted multiple responses, and despite reporting uniform recommendations, 6 had conflicting responses for at least 1 management recommendation, and 3 had conflicting responses on 3. These differences were often major. For example, some respondents recommended return to screening, while others recommended surgical excision. The study highlights the variations that exist in management recommendations for the same pathologic diagnosis. Lack of consensus on management recommendations for high-risk lesions is thought to be secondary to limitations in the available medical literature, including limitations in study designs and variations in reported upgrade rates. In this lecture, I will summarize some of the available data and discuss who, if any, may safely forgo excision following a core biopsy diagnosis of these high-risk lesions based on our current treatment guidelines. In making a decision of whether a lesion needs to be excised, we look at the upgrade rate. We consider a case upgraded when the surgical excision for a core biopsy with a benign or atypical diagnosis yields invasive carcinoma and/or DCIS along with the biopsy area. We'll start by discussing intraductal papillomas. I'll be focusing this portion of the discussion on papillomas without atypia, since as this recent study shows, the presence of atypia carries a substantial risk of upgrade, which is well described in the literature, where upgrades are reported in up to 41% of cases, justifying routine excision of these lesions. Benign papillomas, on the other hand, have a mild increased risk of subsequent carcinoma with an approximately 5 to 7% lifetime risk of developing cancer. This risk is similar to that for UDH. This table summarizes the findings of studies of benign papillomas found on core biopsy and which also assessed RAD-path concordance, excluding discordant cases. The upgrade rates range from 0 to 6.8%, leading most of these investigators to conclude that surgical excision of benign papillomas is not required. Most of the upgrades consist of DCIS, with only a few invasive carcinomas. Features found to be significantly associated with upgrade include clinical symptoms such as nipple discharge and/or palpable mass, larger size, concurrent breast cancer, and multifocality. Dr. Parejo published our MSK data in 2016. They searched for intraductal papillomas diagnosed on core needle biopsy. The histology and imaging were reassessed, and only benign RAD-path concordant lesions were included. They identified 196 intraductal papillomas without atypia. Of these, 171 underwent surgical excision, and the upgrade rate was 2.3%. This table details the 4 upgraded cases, which included 2 showing DCIS and 2 invasive carcinomas, both invasive lobular carcinoma. All the tumors measured 2 millimeters or less. There was residual papilloma in all cases, and in only one case did the carcinoma involve the papillary lesion, deemed a true upgrade, whereas the other 3 carcinomas were at least 8 millimeters from the residual papilloma and so could be considered incidental upgrades. In their study, concurrent ipsilateral breast carcinoma was the only clinical parameter associated with upgrade. These numbers are small, of course. However, we recommend that in the presence of worrisome symptoms, surgical management of the papilloma should be considered. A multi-institutional study found similar upgrade rates. The authors prospectively identified patients with a biopsy diagnosis of intraductal papilloma who had consented to excision. Any discordant cases and any with atypia were excluded. The trial included 116 patients, and per local review, 2 cases were upgraded to DCIS. They also did a central pathology review and confirmed the diagnosis of benign papilloma in 85 cases, and both locally upgraded cases were among them. In both cases, central review could not confirm DCIS for an upgrade rate of 0. The data shows that closed radiologic follow-up constitutes appropriate management for patients with intraductal papillomas without atypia and with radiologic concordance. For cases with atypia or those that are benign but RAD-path discordant, surgical excision is recommended. Let's now discuss mucocele-like lesions. Mucocele-like lesions are a rare finding in core biopsy. Most commonly, they're detected on screening mammograms due to calcifications. Less commonly, they may present as a mass. Microscopically, they're composed of mucin-containing cysts that tend to rupture. The spaces are typically lined by cuboidal to attenuated epithelium, and the epithelium can show a spectrum of proliferative changes, with approximately 1/3 to 1/2 associated with atypia. This table lists studies which examine the upgrade rates of mucocele-like lesions at excision. The studies retrospectively reviewed their databases to accrue cases over an average time span of approximately 16 years, ranging from 8 years in the Sutton study to 21 years in the MSK study by Dr. Edelweiss, highlighting the rarity of these lesions. Of note, in the study by Gabriel, the only case that was upgraded was radiologically discordant. The overall upgrade rate is 9%. However, these numbers include both mucocele-like lesions with and without atypia. When comparing those lesions with atypia to those without, there is a clear association with the presence of atypia and likelihood of upgrade at excision. In cases with atypia, the overall upgrade rate is 17%, compared to 4% in those without. When excluding RAD-path discordant cases, the upgrade rate in those without atypia is 3%. All the studies conclude that the finding of a mucocele-like lesion without atypia on core biopsy does not necessitate excision and favor close imaging follow-up. In the Gabriel and Mosley studies, both upgrades were ultrasound-guided biopsies targeting a mass, and both upgraded to invasive mucinous carcinoma. These findings suggest that for mass lesions sampled by ultrasound, the finding of a mucocele-like lesion may warrant surgical excision to exclude a carcinoma. In the study by Zhang et al., the single patient with an upgrade had low-grade DCIS on excision. This patient had a history of DCIS associated with mucin at a separate site in the same breast. And finally, in these studies, both upgrades in each were small foci of low to intermediate grade DCIS. In summary, the data shows that patients with radiologically concordant mucocele-like lesions with no atypia do not require excision, while we recommend excision in those lesions with atypia or those without atypia but discordance with the imaging findings. We'll now move on to sclerosing lesions. Radial scars and complex sclerosing lesions are part of a spectrum of breast sclerosing lesions, which, like papillomas, carry a 2- to 3-fold relative risk for the development of breast cancer. Radial scars have a concentric architecture with a central hyalinized nidus and radiating arms forming irregular mass or area of architectural distortion on imaging. Complex grossing lesions are more ill-defined. They are sometimes defined as radial scars measuring more than a centimeter in size. Our team published a small study on radial scars found on core biopsy in 2015. Selection criteria included a diagnosis of radial scar without atypia and RAD-PAS concordance. The cases were divided into those radial scars which were considered incidental versus those that were the target lesion of the biopsy. For example, if the target was calcifications, a scar with less than 10% of total calcifications on the slide was incidental. Radial scar was deemed incidental in 13 cases, and no upgrade was seen in this group. In 35 cases, the radial scar was the target, and in one case, a single 2 millimeter focus of low-grade DCIS was identified. The overall upgrade rate was 2%. As part of their study, Conlon and colleagues performed a small meta-analysis. In these studies, the malignancy rate ranged from 10 to 41%, with a mean malignancy rate of 20%. It should be noted that many did not have RAD-PAS correlation to determine if the scar was the target or whether it was incidental. In the small subset of series that did address this, the malignancy rate on excision of targeted radial scar is substantially higher than for incidental radial scar. In this meta-analysis, the authors performed a systematic review, and inclusion criteria are listed here. One major limitation was the absence of information on RAD-PAS concordance. The findings were grouped into categories based on biopsy type, needle gauge, and presence or absence of atypia within the radial scar. 51 papers met the criteria, with data on 3,163 excised radial scars. Overall, the upgrade rate for radial scars with and without atypia was 6.9%. The reported upgrade rates range from 0 to 45%. They found only one study which addressed incidental radial scars specifically, and there were no upgrades out of 18 excised lesions. They found that radial scars without atypia assessed by vacuum-assisted biopsies have an upgrade rate of only 1%. The included study showed only 2 cases of DCIS among 122 lesions. They hypothesized that this low upgrade rate could be because vacuum-assisted biopsies produce larger volume samples and therefore have less potential for undersampling and diagnostic errors. Among radial scars without atypia, there was a small decline in upgrade with increasing needle gauge. In contrast, the upgrade rates for radial scars with atypia are much higher, ranging from 11 to 28%. They conclude that there is a correlation between upgrade rate and biopsy modality, extent of sampling, RAD-PAS concordance, and absence of atypia. A few recent series specifically examining radial scars with atypia on core biopsy are summarized here. The upgrade rate of excision is around 30%. 2 of these studies also compared upgrade rates of radial scars with atypia to those without, and found the upgrade rate to malignancy was significantly higher in the atypia group compared to those with no atypia on core biopsy. Over the past several years, we have been seeing increasing numbers of radial scars on biopsy. One reason for these increased numbers is the integration of digital breast tomosynthesis into standard practice, which has increased the frequency of certain imaging findings, particularly architectural distortion, as this study shows. Tomosynthesis does this by allowing for 3-dimensional reconstruction of the breast, which improves visualization of findings that can be subtle or occult on standard 2-dimensional mammography. This study also shows that radial scars are being identified with increased frequency. The authors compared upgrade rates of radial scars detected with standard mammogram compared to tomosynthesis. They found that the likelihood of identifying radial scars was significantly higher with tomosynthesis imaging. Of the patients who underwent excision, the upgrade rates of carcinoma was similar before and after tomosynthesis, as were findings of a high-risk lesion. Based on our prior study, our policy had been to excise most radial scars, except those which were small and incidental, as well as all complex sclerosing lesions. However, anecdotally, we saw very few upgrades at excision. The increased frequency of radial scars meant increased and possibly unnecessary surgery. And so I recently gathered data to re-examine the upgrade rates of sclerosing lesions. We searched for lesions diagnosed between 2015, the time of the last study, and 2021. We excluded 70 cases, including 27 with a concurrent carcinoma and without a separate excision for the area with the scar. 24 had coexisting ADH, 12 were lost to follow-up, 4 cases did not have slides available for review, and 3 were found to not have radial scar on re-review, but rather focal sclerosis and fibrocystic changes. Additionally, 25 were not excised and were followed clinically. Our final cohort consisted of 130 core biopsies. The median patient age was 52 years. 53 patients had a personal history of carcinoma. Equal numbers of lesions were identified on mammogram and MRI. For those cases using mammography, most used tomosynthesis, 19 were standard 2D, and 1 was contrast enhanced. Most cases targeted architectural distortion, as well as masses, non-mass enhancement, and calcifications. The median diameter of the imaging target was 9 millimeters, with an almost equal split between those more than and less than a centimeter. Most of the cases used a 9-gauge needle, others used 12 and 14 gauge, and the majority were vacuum assisted, but 23 were not, all ultrasound guided biopsies. Again, cases were divided into either incidental or targeted lesions. The lesion was categorized as the target in 99 cases and incidental in 31. 2 cases were upgraded for an upgrade rate of 1%. These are the upgraded cases, both for MRI guided biopsies, one for non-mass enhancement and the other targeting a mass. In case 1, the lesion was considered the target of the biopsy, while in case 2, the lesion was considered an incidental finding. On excision, both showed small foci of invasive carcinoma, and in both, the carcinoma was not closely associated with the biopsy site and are considered incidental. In cases that were not upgraded to carcinoma, 7 excisions yielded ABH. In the 25 patients who did not undergo excision and had follow-up data available, none developed carcinoma or other worsening imaging findings over a median of 31 months. Based on this data, we no longer require excision for RAD-path concordant radial scars and complex sclerosing lesions without atypia. We do recommend surgical excision for any sclerosing lesion with atypia and/or benign lesions if they're deemed to be RAD-path discordant. We'll now discuss atypical lesions, beginning with classic lobular neoplasia. Lobular neoplasia is a marker of bilateral increased cancer risk. The carcinomas that may occur develop an average of more than 10 years after the initial diagnosis. 1 to 2% develop invasive cancer per year. The WHO currently recommends active surveillance and risk reduction strategies for classic lobular neoplasia. Let's review some of the literature now. This table shows that with RAD-path correlation, the upgrade rates range from 0 to 3%, while it's up to 33% without RAD-path correlation. Additionally, in a few studies, the outcomes of the excluded discordant cases were reported. The upgrade rates are similar to those in series without RAD-path correlation. Taken together, these findings support that routine excision after the diagnosis of classic lobular neoplasia on a radiologic concordant core biopsy is not indicated. But what about non-classic forms of LCIS? The 5th edition of the WHO defined histologic criteria for variant forms of LCIS, which include pleomorphic and florid LCIS. Variant LCIS has morphologic and molecular features not present in classic LCIS, including higher nuclear grade and more genomic alterations. Information about the natural history of these lesions is extremely limited. Currently, the WHO board recommends excision for non-classic LCIS diagnosed on core biopsy. Let's look at the morphologic features of these entities. Florid LCIS shows marked distension of TDLUs or ducts, creating a confluent mass-like architecture. Florid LCIS should have at least one of 2 architectural features: little to no intervening stroma between markedly distended acini, and/or acini spanning at least 40 to 50 cells in diameter. The cells exhibit the small, uniform cytologic features of classic LCIS. Florid LCIS can show necrosis and is often associated with calcifications. I want to briefly mention what is meant by extensive LCIS, like is shown in this example, where every lobule in these cores is involved by LCIS, but none is markedly expanded. I want to emphasize that lesions with extensive classic LCIS should not be categorized or considered as florid LCIS and do not require excision. In contrast to florid or classic, pleomorphic LCIS is defined by the presence of marked nuclear pleomorphism, like those seen in high-grade DCIS. Acini involved by pleomorphic LCIS are often substantially expanded, but may be only mildly distended or show no distension. According to the WHO, those cases of LCIS which aren't completely classic but don't fit criteria for pleomorphic should be categorized as classic. This recommendation was for excision specimens. The clinical significance in biopsy material is unknown, and we recommend excision of this variant if identified on core biopsy. This table summarizes studies on upgrade rates when non-classic LCIS is identified on core biopsy. Cases are most upgraded to invasive carcinoma. The upgrade rates range from 19 to 60%, with a total upgrade rate across the series of about 37%. I'll now discuss the MSK study on this topic. In this study, by Dr. Kuba, they searched approximately 30,000 in-house core needle biopsies and identified 218 with the diagnosis of non-classic LCIS. Of these, they further excluded 163 cases which had an associated high-risk lesion, 11 patients were lost to follow-up, and 8 cases had no slides available for histologic re-review. The final study cohort consisted of 36 core biopsies. Most common method of biopsy was stereotactic. The majority of biopsies were performed for suspicious calcifications. Other targets included non-mass enhancement, masses, and architectural distortion in one case. All cases were re-reviewed by at least 2 study breast pathologists and confirmed by absence of E-cadherin staining. Cases were divided into pleomorphic LCIS, florid LCIS, and LCIS with pleomorphic features. The pleomorphic and florid groups were further divided based on presence or absence of necrosis. All upgraded cases consisted of invasive carcinoma, predominantly present as microinvasive foci. The LCIS with pleomorphic features had no upgrades. The overall upgrade rate was 19%, excluding those with pleomorphic features. The radiologic target was calcifications in all upgraded cases. The only clinical pathologic feature that significantly correlated with upgrade was the extent of non-classic LCIS on excision. However, the presence of necrosis showed a positive trend. They conclude, as do the other studies we reviewed, that these findings support surgical management of these lesions. In summary, given that non-classic LCIS is frequently associated with DCIS and/or invasive carcinoma, these lesions should not be managed as classic lobular neoplasia, and excision should be recommended even if RAB-PATH concordant. Now we'll discuss flat epithelial atypia, or FEA. The relative risk of subsequent breast cancer in women with FEA only is 1.5 times that of women without FEA. The risk is similar to that of UDH. The WHO consensus recognizes the wide variation in the reported upgrade rate of FEA at excision, leaving the need for follow-up excisions somewhat open, with the understanding that RAB-PATH correlation is recommended for determining further management. These are a few studies that analyze the upgrade rate of FEA. Finding of biopsies with FEA as the highest risk lesion is rare, so all the series are relatively small. The observed upgrade rate varies widely, ranging from 0 to 36%. Note that not all studies assess radiologic pathologic concordance. The highest rates of upgrade are reported in 2 studies that did not assess RAB-PATH concordance. Of note, despite reporting an upgrade rate of 36%, Martel and colleagues did not recommend routine excision of FEA, but advised in favor of close imaging follow-up. In 4 studies, the invasive carcinoma was deemed an incidental finding as it was small and not related to the biopsy site. All these results need to be interpreted with caution as their applicability relies on the reproducibility of FEA as a diagnostic entity. Samples and colleagues assess reproducibility and the diagnosis of FEA. This graph shows the proportional agreement in diagnosis of 6 reference cases of FEA, each reviewed independently by 29 to 30 pathologists. Agreement with the diagnosis of FEA ranged from 52% in case 1 to 17% in case 6. Other diagnoses made include columnar cell hyperplasia, UDH, ADH, and other benign lesions. Interestingly, in case 5, one of the diagnoses rendered also included DCIS. The authors concluded that there is substantial and somewhat concerning variability in the diagnosis of FEA due to difficulties in the interpretation of this lesion. Because of the poor inter-observer agreement on this diagnosis, I wanted to briefly review the histologic features of FEA before I discuss our own analysis of this topic. The WHO defines FEA as the replacement of native ductal cells by a flat proliferation consisting of 1 to several layers of cells with low-grade atypia. However, at our institution, we routinely limit the diagnosis of FEA to lesions with at least 2 layers of atypical cells, as shown in the image on the left. In contrast, we classify as columnar cell change lesions with a single layer of columnar cells, as shown on the right, and these lesions are not excised. The involved TDLUs are variably distended without architectural atypia and may contain interluminal secretions and calcifications. Here, the acini are enlarged and dilated with smooth contours. The ductal cells display low-grade atypia with round and uniform nuclei without prominent nucleoli. The cytoplasm tends to be increased and accumulates in apical poles, forming tall cytoplasmic snouts. An important diagnostic feature is the lack of any evidence of architectural atypia. If architectural complexity is present, the lesion is better characterized as ADH, even if the changes are minimal, like a single atypical interluminal structure such as a bar, Roman bridge, or micropapillary formation. Again, FEA maintains a flat appearance, while the proliferation of ADH can be solid, cribriform as shown on the right, or can show micropapillary projections. While not a criteria noted in the WHO, we have often identified that the myoepithelial layer is attenuated and at times almost undetectable, as shown here. This is in contrast to benign epithelial proliferations where the myoepithelial cells can be especially prominent and may form a continuous ring around the glands, as shown here. I'll now discuss the MSK data, which we published a few years ago. Out of about 16,000 core needle biopsies over a span of 6 years, there were only 106 with a diagnosis of FEA, for an incidence of 0.7%. We further excluded 52 core biopsies, 40 from patients with prior or concurrent carcinoma, and 12 without follow-up resection. Upon review of the remaining 54 cases, 40 cases of FEA were confirmed, and we further excluded 14 that were reclassified. In the final FEA study cohort, FEA was present alone in 85% of cases and with classic labial neoplasia in 15%. All 40 cases were deemed to be RAD-Path concordant. The target was calcifications in 90% of cases, and the overall average lesion diameter was approximately 9 millimeters. At excision, there were 2 upgrades to carcinoma for an upgrade rate of 5%. The findings in the 2 cases are summarized in the table. Both core biopsies sampled a large area of calcifications. In both cases, surgical excision yielded invasive carcinoma. And notably, in both, the invasive carcinoma was found on tissue section separate and not associated with the biopsy site, and so could be considered incidental findings. We conclude that when strict diagnostic criteria are applied, the upgrade rate at excision of FEA is low in patients without prior or concurrent carcinoma and with RAD-Path concordant core needle biopsy findings. Non-operative management of the FEA may be considered in these patients. Final topic I'll discuss is ADH. The absolute risk of breast cancer after the diagnosis of ADH is approximately 1% per year for at least 25 years. ADH is distinguished from DCIS based on architectural complexity and extent, according to guidelines developed from the examination of excisional biopsies. Due to limited material provided in core biopsy, it's not always possible to use quantitative criteria for distinguishing ADH from low-grade DCIS, so it's logical that approximately 30% of ADH cases are upgraded on excision. Surgical consultation is therefore generally recommended. However, some have proposed observation alone for small amounts of ADH. This study by Eli and colleagues aimed to try to identify which cases of ADH would be more likely to be upgraded on excision. 47 cases were the basis of the study. All cases were categorized based on the extent of ADH, which was determined by evaluating the number of TDLUs affected. Cases were divided into 3 groups. On excision, there were no upgrades in the first group, in contrast to 13 upgrades in the third group. This difference was statistically significant. Those in group 2 were equally likely of being benign or malignant on excision. The overall upgrade rate for the whole cohort was 36%. They concluded that when ADH involves 4 or more foci, excision is recommended. However, patients with limited ADH probably do not require excision, especially if the mammographic target has been removed. Building on that prior work, this study from MD Anderson selected patients who had ADH on a biopsy done for calcifications, ended up with a cohort of 140 patients. 121 patients had an excision, and 19 did not or followed clinically. Cases were reviewed and several histologic features were noted, including extent of ADH as defined by the prior study, the histologic pattern of ADH, the presence of significant cytologic atypia, suspicious for an intermediate or higher grade DCIS, and the presence of necrosis. The upgrade rate was 13%. Cases were more likely to be upgraded if they had less than 95% of calcifications seen on imaging removed with the core biopsy, if more than 2 TDLUs were involved by ADH, if there were significant cytologic atypia, and necrosis. That group followed up their study to examine the long-term safety of observation in those patients they had deemed to be at low risk for upgrade. We just reviewed their original observation criteria. Over the years, their criteria expanded to include those with more than 50% of calcifications removed and no mass lesion or architectural distortion. 635 patients met eligibility criteria, and 152 were excluded for the reasons listed here. The final cohort included 174 patients who had surgery with benign findings and 309 who were clinically observed. 96 women had a personal history of breast cancer. The median follow-up was 5.2 years. Women less than 50 were more likely to have surgery, and those diagnosed by stereotactic biopsy were more likely to be recommended observation than if diagnosed by ultrasound or MRI-guided biopsy. On multivariate analysis, prior history of breast cancer was the only factor significantly associated with subsequent breast cancer risk. After excluding patients with personal history of breast cancer, 21 patients developed a carcinoma, including 11 DCIS and 10 invasive carcinomas. Analysis of the subset showed no association between risk of upgrade with age, race, use of chemo prevention, surgical excision of the ADH, or imaging modality used. Less than 2% of cancers in each group developed at the index site or the site of the prior biopsy. So they concluded that in selected cases, observation is safe. In contrast, this is a brief summary of some data we recently published on the upgrade rates of ADH on core biopsy. We identified 208 in-house core biopsies with follow-up excision. We further divided those into cases with focal ADH, which we defined as one focus spanning less than 2 millimeters, and non-focal cases, which was everything else. The upgrade rate of cases with focal ADH was 7%, compared to 22% in the non-focal group. On multivariable analysis, only the extent of ADH was significantly associated with upgrade rate. The upgrades consisted of 5 DCIS and 2 sub-centimeter tubular carcinomas. The 7% upgrade rate is not sufficiently low to recommend routine observation in these cases. We concluded that these results may be best applied in the management of patients with a biopsy diagnosis of focal ADH and comorbidities where non-surgical management may be considered. In summary, we continue to excise all core biopsies which carry a diagnosis of ADH. However, if clinical need arises, imaging follow-up for a biopsy diagnosis of focal ADH can be considered. This table summarizes what we just discussed. I'd like to thank you for listening, and I can take any questions. Thanks.
Thank you so much, Dr. Grabenstetter. That was an outstanding summary of all difficult lesions. Just before Doctor will proceed further, I would like to introduce Dr. Anna Marie Mulligan from University Health Network, who is our expert for the day, and Dr. Sharon Nofech-Mozes, who is another breast pathologist at Sunnybrook Health Sciences Center, who will be also an expert for today's session. And Jessie, maybe you can proceed with the questions that we have already in the chat.
Sorry, yeah. So we've got quite a few questions already. So I'll start off with the first one. So it's about what is the definition of atypia in a radial scar?
Atypia, like you would see anywhere else, you know, if there's predominantly ADH, but it wouldn't be for ALH. It would be if there was ADH or I suppose FEA in the scar or DCIS. Any kind of atypia that would normally be excised.
I see. And are there any cutoff for pleomorphism and or kind of nuclear size when you're diagnosing pleomorphic LCIS?
So they say in the WHO that the cell should be about 4 times the size of a normal lymphocyte. If there's a lot of nuclear pleomorphism, I think that qualifies. Typically, you see a lot of mitotic activity, that kind of thing. I mean, it's something that you would recognize almost instantly, just like you would a high-grade DCIS.
Okay. And also, how often would you use beta-catenin for diagnosis of LCIS if the E-cadherin shows aberrant staining?
I'm sorry, can you repeat the question?
Oh, so the question is about, so in cases of LCIS, if E-cadherin shows aberrant staining, how often would you use beta-catenin?
We don't routinely use beta-catenin here. We do use P120 catenin. I like to use both at once, just in case there is something funny about the E-cadherin. P120 is a little bit more specific, so it's good to get a sense of what's going on with the cadherin-catenin complex when you use both of those. Yeah, I mean, beta-catenin you could also use. We just don't routinely use that here for lobular lesions.
Okay. Okay. So in breast biopsy, if there is high-grade atypia in ADH, do you call it DCIS without considering the size?
Yes. If it's not low-grade atypia, if there's higher-grade atypia, then it should be called DCIS regardless of the size. Sometimes if it's very minimal, we won't necessarily call it DCIS in the core biopsy, but we'll make a comment that it's not ADH either, and we'll say there's a proliferation of marked ductal atypia. A lot of this has to do with sometimes the patient age or the other characteristics of the patient or the biopsy, but typically if there's higher grade nuclear features, we'll call it DCIS.
Okay. And I've got a question myself, actually. So kind of considering what you've kind of discussed already, how receptive are the surgeons to these study outcomes? I mean, do they actually adhere to these recommendations,
actually,
or do they pretty much do what they want?
No, I mean, yeah, surgeons will always just do what they want, but they're pretty receptive to it. I mean, a lot of them like to hear this kind of information, that they don't have to keep excising lesions. There's, we consider these kind of minor surgeries, but every surgery carries a certain degree of risk and can have, major complications. And so they're actually quite pleased when we say, hey, you don't have to keep excising this. I don't know if that's just because they have other things to excise or what, but yeah, they like it. So this ADH study I did, it was a little bit disappointing because then we weren't gonna stop excising anything, even though we thought possibly we could for the minimal stuff like they do at MD Anderson. But the radial scar, complex exposing lesion things, they're overjoyed. They don't have to excise it. Stuff like that. Yeah.
And have you had any feedback from radiologists in that it seems like a lot of this has to do with kind of radiologic pathologic correlation. So how do they find like all these recommendations, seeing that they have a lot of pressure on getting things right?
I think they like it too. We always include in every study that we do here at MSK for something like this, there's always a radiologist in the study and who re-reviews all of the imaging. Nothing is based just on reports. Everything is re-reviewed and everything is discussed. And, final recommendations are always run by whoever was on the study. And then, the heads of each of the teams, the surgeons and the radiologists and all of that, to make sure everyone's on board before we kind of put it out for everybody to adhere to. So it's not just us as pathologists saying, this is the policy. It's always discussed. But yeah, they don't mind it. They don't mind it either, as far as I know.
And we have a couple more questions. Okay. Do you usually write recommendations based on these new criteria?
No, we have so a chart like this, or not this chart specifically, but another chart is distributed to all the radiologists, and also the surgeons have it, the physician assistants, the nurse practitioners. So we don't have to write specifically. They know what their policy is, and everyone here adheres pretty much to the standard protocols. So everyone knows what it is, and if they don't know, they'll email us and ask us if we think it needs to come out. If there was something that we really thought should be excised, we would put a comment, but otherwise we don't feel the need to do that because we make sure everyone's on the same page here.
Wow, very impressive. So the next question is with regards to flat epithelial ectypia. So given the possible inter-observer variability and management implications, where does FEA stand as a diagnostic entity?
Like, is it one?
I suppose.
I think that it is. I mean, we still see a lot of variability, and when we stopped excising it for a subset of our patients, a lot of times we would recommend that you get at least one other person to agree with you. So we were seeing a lot of these at our consensus conference. I think everyone is a bit more comfortable in diagnosing it, but we still see it quite frequently. I mean, it is a thing. It's very difficult to reproducibly diagnose, but it carries a very low risk of upgrade. So I feel like even if it is missed, it's okay. If it's overcalled, the patient might get a somewhat unnecessary excision, but at least it's out, and then you can handle it from there. I don't know if that answers your question. I mean, it's a thing, but yeah.
Oh, sorry, Anna Marie had your hand up. Did you want to ask a question?
Oh, thanks, Jessie. Yeah, no, it was largely answered. I was just going to ask about whether or not these cases come to RAD-Path rounds in general, and also from that then do you include routinely a recommendation for excision, which you've answered, and does it depend on whether it's an in-house case or a consult? I guess personally I'll only include an excision in the case of ADH or a non-classic pattern of lobular neoplasia. Most of the others that you know, we're not excising routinely. I don't include anything, but I might change that if it's a consult, just because it's a different group of surgeons or radiologists that will be accessing that. So it's easier when you know your audience and you know that you're all on the same page. But it's also very interesting to see how things changed over the years. When FEA first came out, our surgeons, they were taking them all out, and now you know, they kind of pass over, oh, it's just FEA, and they rarely kind of request that we discuss that in any further detail. So yeah, so it's just a question really regarding how you approach these high-risk lesions in your reports.
Yeah, so we don't have like a formal RadPath rounds like they do at a lot of other places. I just don't think we have the time. But all the pathology, all the radiology reports, after the pathology is released, there's an addendum that's added indicating if they think it's concordant or not. Yeah, and I guess the other part was just if we put any comments in our report. Sometimes we'll do for, like for ADH, even though we still excise everything, every now and then we'll put a comment that it's minute, or, you know, it's very small. That doesn't necessarily change how they're going to approach it. Most of them will still excise. All of these recommendations are supposed to be based only on our in-house material, because we don't use submitted material when we're analyzing these things. And we always have, we're always a little bit hesitant to just say, oh, we shouldn't take it out just because this is our policy here, because we don't know always how accurate the radiology is from outside or how good the biopsy was done. So there's always a bit of a caveat. And sometimes, you know, if we're really concerned or something like that, but you know, the radiology is also reviewed here, just like all pathology is reviewed for any patient that comes for care, if they've had it done on the outside. So there's an assessment there, and then the radiologist will decide how to proceed. And there's usually a discussion, typically via email, on what we think, and then what the radiologist thinks and what the surgeon might think. But yeah, did that answer all of your questions?
Yeah, no, that's great. Thank you.
And I've got another question. So this is from someone who missed the beginning of the presentation. So the question is, do you use the size of intraductal papillomas as an independent risk factor?
We don't. I know that there are some studies that show that size can impact upgrade. Our study done at MSK did not find that, so we don't. Usually if they're symptomatic, so if they're larger and they're causing a palpable mass or some discomfort, they'll take them out even if they're benign. So I suppose in that respect, you know, kind of the clinical assessment of it, but we don't have a cutoff, no.
All right, are there any other questions? Okay. Well, I think that's all the questions we've got. Thank you so much for your very informative talk. It's excellent. We really appreciate you taking the time to give us this talk. Thank you.
Yeah, thank you for listening, everybody. Thanks for having me too.
All right. So next we'll move on to our case presentations. Our first presentation is coming from Dr. Pratibha Iyengar from Trillia. Pratibha, would you like to share your case?
Yeah, can you hear me?
Yes.
Okay, so I'll do the share screen. So hi everyone, I have two cases to present. The first case, Jessie, I see you can see the slides. Yeah, okay.
Sorry, yes.
Thanks. The first case is an 84-year-old woman. Unfortunately, she was quite frail, living in a nursing home, and had Parkinson's disease. She presented with a very large 8-centimeter mass in the breast with axillary adenopathy. When the surgeon examined her, he did comment that there was evidence of inflammatory breast cancer with peau d'orange appearance. And therefore, he opted to only do the breast core biopsies and a skin punch biopsy, and didn't sample the nodes given her age and the medical comorbidities. So I'm going to switch and show you the slides that we have scanned. Let me know if there's any issues with them. So these are the core biopsies from the breast. As you can see, there's poorly differentiated malignancy seen. We do have some small benign breast ducts. If I focus on the malignancy, it looks like hyperchromatic cells with nuclear molding. There's a fairly brisk mitotic activity, which I hope you can see. I think the chromatin is not as well seen in the scan, but there were areas of necrosis, which I think maybe it's better seen in this core. So areas like this. And high mitotic activity, we said, and necrosis here as well. Another H&E of the same case shows similar findings with respect to the tumor. There were only a few areas that were a little bit different, like this rounded structure here with the intraductal proliferation, that we were suspicious about DCIS. So we did a full panel of immunostains. The patient didn't have any significant past history to help us. So we have a triple stain in our department where we do a red chromogen for the cytokeratin. And this also includes P63 and myosin with the brown chromogen. So you can see that the tumor does have some cytokeratin staining. And this little in situ component that we were suspecting does have retained myoepithelial staining. Some of the other stains we did included GATA3, which was positive. CD56 was also strongly positive in this case, as you can see here. Synaptophysin was positive. The chromogranin was also positive, but it was much more focal and weak. You can see here. We did TTF1 and napsin. Out of curiosity, it was negative. And we also did a Chi61, which was quite high, as you can see here. With respect to breast biomarkers, the tumor was ER negative, and we had some good internal controls with those benign breast ducts. The same was true for PER, that was negative as well. And the HER2 was negative also with the score of 0. So this was a quite interesting case. Just going to switch back to my presentation. So in summary, the tumor was keratin positive, GATA3 positive, and the neuroendocrine markers were positive, negative for GCDFP, TTF1, napsin, CK7, CK20, lymphoid marker, and so-called triple negative with a high proliferation index. So we felt that this was a case of a small cell carcinoma of the breast, which are quite rare. In this case, because of her medical comorbidities and the extent of the disease, they decided to go ahead and treat her with chemotherapy as well as radiation treatment, which she was able to tolerate despite her age. But unfortunately, she developed liver metastases and passed away within a year of the diagnosis. So I'll just move on to my second case. The second case was a younger patient, 52 years old, who had a history of ipsilateral DCIS and had been previously treated with a lumpectomy and radiation. And she was now presenting with what they thought was a recurrent breast cancer, carcinoma in the same breast. And on core biopsy, had been diagnosed as a routine invasive ductal cancer with the luminal A type, ER/PR positive, and HER2 negative. And I got the excision on this case. So I'll show you the slides. So at first, we had what looked like a routine invasive cancer with some DCIS, like you can see here. But what was interesting in this case was that there was another element where there was a more poorly differentiated malignancy that was quite in proximity to this routine invasive breast cancer. And you can see more of it here. And again, this very poorly differentiated malignancy with these hyperchromatic cells, a high NC ratio. Again, as you can see, a very brisk mitotic activity. I'll just show you another slide. Again, this one is again showing the combination of what looked like the routine invasive cancer and then this higher grade malignancy. You can also see here. And then in fact, the majority of the remainder of the sections of the tumor just showed this high grade malignancy. So we again did immunostains on it, and I'll keep them brief in the interest of time. This again is our triple stain with the keratin as the red chromogen. And you can see that the DCIS component showed nice retained myepithelial staining. This was a low molecular weight cytokeratin used in this cocktail, and this high grade malignancy did not stain for it as well. But when we did a pan cytokeratin, there was staining in this high grade area. And then when you look at the neuroendocrine markers such as synaptophysin, sorry, they scanned the slide upside down in this case, but here again in the routine invasive cancer, there was not appreciable staining, whereas in the high grade malignancy area, you can see nice synapto staining, and the same was true for both chromogranin, and this is CD56 showing staining in that high grade area. The Chi67 was also quite high in this area. And then switch back to the presentation. So in summary, in that area that we thought was more in keeping with small cell, that high grade looking area, it was positive for a pan cytokeratin, the neuroendocrine markers. Some of the markers I hadn't showed, but it was negative for GATA3, GCDFP, TTF1, CD45, and melanoma cocktail. And interestingly, the biomarkers were quite different in the two areas. Similar to what was seen on the core, the invasive ductal carcinoma was ERPR positive. HER2 was equivocal and negative by FISH studies, whereas in that small cell region, it was more of a triple negative phenotype. So we signed out this case as a mixed invasive ductal carcinoma mixed with a small cell carcinoma component. So just had a, I'm not sure if I'm okay for time, Jessie, but if I have time, I'll just present. I find these neuroendocrine tumors of the breast quite challenging. And I keep having to reread the WHO section whenever we get these. But in reading them, and things have changed between the last set of WHO and now the current 5th edition. They do point out that there's some entities that express neuroendocrine markers, but which we should consider as distinct entities. And we know about solid papillary carcinoma and probably the hypercellular variant of mucinous carcinomas, which can have these neuroendocrine staining. And then they divide neuroendocrine neoplasms into these two main categories of neuroendocrine tumors, which are more the low intermediate grade morphology, and then neuroendocrine carcinomas. They do give us some tips on neuroendocrine tumors that the vast majority probably represent mixed tumors where there's a component of a conventional type mammary carcinoma like we saw in our second case. And similarly, the majority of these primary small cell neuroendocrine carcinomas of the breast show a component of the conventional type mammary carcinoma. And if the small cell component makes up about anywhere from 10 to 90% of the tumor area, they advise to use the terminology for mixed and give a percentage for the neuroendocrine carcinoma component. Cases that have less than a 10% neuroendocrine pattern should be classified as invasive NST with an option to describe this neuroendocrine pattern. And cases with a greater than 90% neuroendocrine pattern should be classified as either this low intermediate grade neuroendocrine tumor, or if it's high grade, in this neuroendocrine carcinoma category. Since our cases dealt more with the high grade end, I've just had my closing slide about neuroendocrine carcinomas of the breast. So they can be divided into small or large cell carcinomas. They are extremely rare, and clinical syndromes that we often think about in neuroendocrine tumors from other sites, such as GI, are not documented in breast cases. Similar to lung tumors, small cell neuroendocrine carcinomas can display P53 and RB1 somatic alterations. And the morphology is really indistinguishable from what you would expect to see in a lung small cell carcinoma. But it is nice to see this DCIS component to help make a diagnosis of primary small cell of the breast. And as we said, at least half the cases are associated with an invasive ductal NOS or an invasive lobular carcinoma. And they're positive for keratin, GATA3. There can be patchy TTF1 staining, but usually it's not strong or diffuse. And it also may depend on what clone of TTF1 your lab is using. And ER and PR staining has been reported in small cell carcinomas, anywhere between 30 to 50% of cases. In both our cases, they were triple negative. And these are thought to have a worse prognosis than other neuroendocrine tumors of the breast. They can often have nodal metastases or distant metastases. When it's localized to the breast, the WHO recommends treating these as otherwise routine invasive breast carcinomas. But in a metastatic setting, they might try regimens similar to those used in small cell lung cancer. And so far, there's known well-established etiology and no association with smoking. So I just thought I'd share these two interesting cases. Thank you.
Thank you so much for presenting these very infrequent cases. I don't think I've actually seen any myself in the breast. So are there any questions? So I'm just checking the chat to see if anyone's done anything.
I don't have a question, but I just want to, first of all, these were very interesting cases, Pratibha. I also feel that probably pathologists who are not signing in a site-specific sign-out have an advantage here over expert breast pathologists who are looking at breast day in and day out, because as Jessie said, we hardly ever see these cases. And if you are a pathologist who are not doing site-specific, I think that you are in an advantage here over us, because you see these in other sites and probably your eye is triggered more quickly to enter this into your differential diagnosis and actually develop an appropriate IHC panel. So thank you for bringing it to our attention.
Yeah, no problem. Yeah, it's true. The first case that was just the core biopsy, you could think that someone, I think if we hadn't thought of doing neuroendocrine markers, potentially we could have called it just a high-grade invasive duct NOS that's triple negative.
Yeah.
So I think, yeah, the thought of, because I think oftentimes a lot of breast cancers can have neuroendocrine like staining if you do them, but we don't often do them because there's no routine use for it. So I think in these high-grade carcinomas, you really have to think about it to get there to that diagnosis. So yeah, recently I've apparently joined the lung team and I'm now apparently a lung pathologist. So hopefully I'll recognize these more.
Yeah. Yeah. I actually tend to show it to the lung people when I'm thinking about it.
Yes, yeah. The second case I had with that mixed, I was debating whether that high grade could also fit large cell neuroendocrine, but we thought that the lung people thought that there wasn't as much cytoplasm, the nucleoli weren't as prominent, so it's probably better put into the small cell. But yeah, definitely getting help from colleagues in the lung group was definitely helpful.
Well, brilliant. Thank you so much for your interesting presentation. Next, we have two presentations from Dr. Marilyn Mirknek from Mount Sinai Hospital.
Hi, Jessie. Thank you.
Hi.
Let's see, I'm going to try and share my screen. Can you see the slide or the screen?
Yes, yes.
Okay, perfect. So since our last meeting, I had a little bit of a series of very interesting cases. There were 4 of them, but for the interest of time, I'm just going to show 3 of them and something to keep at the back of our minds, because they do crop up every now and then if we don't really think too much about it, easy to miss. So the first case is a 83-year-old woman, no prior significant history other than recent diagnosis of AFib and some shortness of breath. She did have a large right breast mass, almost 8 centimeters in size, that was extending all the way to the skin. And they did an ultrasound-guided biopsy. This was done at an outside institution. A diagnosis of invasive ductal carcinoma, no special type, was rendered. Case was sent to us from a colleague who usually will send them for biomarker consultation, and then every now and then he does add a note that says, please confirm the diagnosis. So this is the low power view of the case, and it does show these kind of nests of infiltrating neoplasm in the background of stroma. Nothing that looks well-rounded or in situ component. When we go to a bit of a higher power field, you can see that these cells, solid nests, they do have abundant cytoplasm, prominent nucleoli. Mitotic activity is easily found, and every now and then you find these really larger, kind of a smudgy looking nuclei. Another area, so mitotic activity easily identified, and you can think, well, could this be kind of just an apocrine looking breast cancer, or is this something else? So when I usually do my routine biomarkers, if I have something higher grade and no in situ component, I may throw in 1 or 2 markers just to, as a kind of a reassurance. So this was triple negative. ER was completely negative, as was PR. HER2 1+, and then GATA3 was negative. Really good positive control with the lymphocytes in the background. SOX10 gave this kind of really weird weak staining. She wasn't sure what to make of it. PAX8 was negative. Napsin was positive. TTF1 was diffusely positive. So this was a metastatic lung carcinoma. After the diagnosis, patient underwent a pan scanning, and that showed there was a really large right middle lobe, almost 10 centimeter mass that was extending to mediastinum. There was a mass effect on her heart and large vessels, probably what might have been causing her AFib and shortness of breath. And then in the CT abdomen, pelvis, they did also identify a left adrenal metastases that was 4 centimeters in size. So case number 2 was a 63-year-old woman, right upper outer quadrant mass, identified on mammo with a 9 centimeter span of kind of linear looking calcifications, and was described as highly suspicious for at least DCIS. Ultrasound found there was an ill-defined mass, almost 3 centimeters in size, and ultrasound needle core biopsy was done. This was an in-house case, so it's a lower power view of the needle cores. Some that looked nice and rounded nests, maybe DCIS, and then some that are a bit more jagged and infiltrative looking. And we take a look at the intermediate power. There's a bit of that central necrosis. Some of these areas looked a little bit more columnar, which was kind of a little bit unusual, but you know, something you sort of think about it, columnar looking cells, some dirty necrosis, okay, maybe additional workup. And then the infiltrative component just kind of did not have any particular specific look to it, but it was a bit unusual. And then CK7 was negative, GATA3 was negative, nice internal controls with some entrapped breast ducts. CK20 was sort of focally positive in places, but CDX2 and SADB2 were diffusely positive. So this was a metastatic colorectal cancer. So we were never given a history, but the patient did have a history of rectal carcinoma with kind of a local extension into the pelvis. But now that she's been rescanned, they showed new metastases in the liver, 4 centimeters in size. There were metastases in bone, predominantly spine, iliac crest, and ischium, as well as breast. There were also very prominent peritoneal, retroperitoneal nodes, abdominal pelvic lymphadenopathy, and she was on palliative FOLFOX chemotherapy last time I checked. And the last case was a 69-year-old woman. There was no significant past medical history, just a note of past history of alcohol abuse. And in August 2023, she felt discomfort in the left axilla. Mammogram was negative, but on ultrasound, they found a heterogeneous, nearly 3 centimeter mass in the left axilla/axillary tail. It was kind of hard to describe exactly where it was, but they were prominent axillary lymph nodes. And she underwent ultrasound-guided needle core biopsy. And it looks at a very fragmented specimen on low power, kind of cellular and busy with some prominent vessels. So kind of on low power invokes could be some kind of a papillary lesion. But when you look at the higher power, there's quite a bit of necrosis in the background and some viable cells around the vessels, but you don't really get a hint of that this is a papillary lesion. In areas, cells do look discohesive and a bit more well-preserved and more cohesive around the vessels. Again, a lot of mitotic activities, apoptotic bodies, occasionally prominent nucleoli. This was CK7, N20 negative, GATA3 was negative, SOX10 did light up. It was also triple negative ERPR HER2, but what was positive is melanoma markers, melanA and HMB45. BRAF immunostain was negative, but our molecular identified an NRAS mutation. So this is a metastatic melanoma. To my knowledge, they did not identify a primary. There was no skin lesion on a subsequent clinical note. So metastases to breast, they're very rare, up to 1.1% of all breast malignancies, and up to 0.4% of these are systemic involvement by hematological malignancies. They generally represent advanced stage of diseases in older patients. However, for up to a third of patients, it could be a first presentation of metastatic disease. And most common sources do tend to be lymphoma or leukemia, melanoma, carcinomas, in younger patients, sarcoma, especially rhabdomyosarcoma, malignant mesothelioma, neuroendocrine tumors, and if you have something that's squamous, cervical squamous cell carcinomas to consider. Of the carcinomas, most common tend to be lung, ovarian, gastric. In men, prostatic, something to think about, renal cell carcinoma, and colorectal carcinoma. A couple of helpful hints, always unusual histology. It's kind of hard to say this because invasive ductal carcinoma of no special type has so many different faces. So what's unusual is almost in the eye of the beholder at times. Lack of in situ carcinoma is really helpful, especially when you have something high grade, older patient, absolutely no in situ carcinoma. They describe predominant periductal, perilobular distribution. This is really hard to appreciate on a needle core biopsy, especially for such large masses. An extensive LVI, but again, none of these are specific. Clinical history is very helpful. However, most of the time we don't actually get that, so it's just a breast mass. And even when you go in imaging, it's just either breast mass or calcifications, but something that would really help us. So that's all I have for the first presentation.
Well, thank you so much for this amazing presentation. I think this again just illustrates how easy it is to kind of forget about metastasis to the breast. I can kind of see myself easily signing these out as triple negative, grade 3 invasive ductal carcinomas.
Yeah, they can be tricky, and sometimes even the clinical notes can be a bit misleading. The fourth case I didn't show was a patient that was, BRCA positive, had a history of breast cancer, and now has got a supraclavicular lymph node, and obviously on the requisition is query recurrent breast cancer, and it ended up being a high-grade serous ovarian carcinoma. So something always to consider, yeah.
Just a comment, Miriam, they were a great collection of cases, and that you had so many in such a short period of time is also shocking. So I've had... Sorry, go ahead.
Yeah, it was a little bit scary because, you see one, you're like, okay, and then you get another one, and it's like, okay, and then you get the third one. And usually they say things will happen in threes, but it just makes you a bit more worried. So every time I get something that's, high grade, no DCIS, it's like,
Absolutely. And I've had a cluster of cases that turned out to be METs. Not all of them did I pick up to be a MET before I signed it out. So that's always less than ideal, and I had to go back and amend. But it's come to the point now that, after I look at a case and say, okay, it's invasive, I start asking myself, Well, am I happy it's a primary to the breast, or could it be a met? So given that most of our cases we can't wait for the biomarkers before we sign it out, I will go ahead and sign it usually, but add in the background I might add a GATA3 and a PAX8 just to make sure as a screen that I'm not missing a met. And they're not always high grade. I had one of my misses was a case that turned out to be a metastatic neuroendocrine tumor from the small bowel, which on the core was signed out as ductal. Then I got the excision. At this point, we were doing biomarkers on the excision, so I signed it out. And when it came back as triple negative in this low grade setting that had a sort of solid papillary carcinoma look to it, a neuroendocrine look to it, I then had to revise it. So it is always something in the back of my mind when I see a breast, if there's no in situ component with it. I look for, things like elastoses can help, calcifications, although some metastases can calcify. And biomarkers don't always help because, non-breast tumors can be ER positive as well. Usually not as diffusely or strongly positive as what we see in breast. But yeah, it seems to be in the forefront of my mind rather than the back of my mind. And I guess we experience sometimes leads us down a different path, how we're affected, so I think about it probably more than I should, but yeah, they're great cases. Thank you.
I do have a question. So this is about neuroendocrine tumors of the breast. So Pratibha, you can jump in as well. So this question is, how do you classify neuroendocrine tumors of the breast which have low or intermediate nuclear grade, kind of carcinoid-like morphology, but which have high mitotic rate, giving an overall high Nottingham histologic rate. For example, T3N2M. Okay, so that's 323. And then in the WHO essential diagnostic criteria, it states NETs are not high-grade neoplasm. So there's a bit of a gray area. How do you actually deal with that when you have like high mitotic rate, but kind of low to intermediate nuclear grade features?
If I'm to answer the question, the WHO says to use the Nottingham grading. So if you do have 323, it kind of ends up being high grade. I think the question to run by our clinical colleagues that regularly see neuroendocrine tumors is, if you do have such high mitotic activity, is it really, do you consider it a low grade? Like if you're having a high Ki67 or a lot of mitoses that you see, where would those actually fall? Like that would not be a typical kind of a carcinoid type of a tumor now, would it? But luckily I haven't had a lot of these to see. I only had one that I can really truly call a neuroendocrine carcinoma of the breast. I don't know if Pratibha, who's now our also breast/lung expert, would could comment.
Definitely not an expert, but yeah, I do. It is kind of confusing because, as the person points out in the WHO, there's only net grade 1 and grade 2 in the WHO. There's no 3 like you have for GI and other sites. So I suppose this is sort of fitting into maybe it's falling into the grade 3 net, but if the Chi is very high, then I don't know if it takes it out of the neuroendocrine tumor category, but maybe I'll defer to Anna Marie and Sharon on this if they've seen that. I personally haven't seen. The only other neuroendocrine tumor I've had was low grade.
So neuroendocrine differentiation in breast tumors, it's a hint of anything that suggests neuroendocrine. I do tend to go to my endocrine colleagues. So I guess the first point I'd make is that lots of breast cancers will express neuroendocrine markers, and that doesn't put them into a neuroendocrine category. I think the exceptions for that neuroendocrine category are the two great examples that Pratibha shared with us, although I haven't come across those myself to comment on personally. But whenever I go to my endocrine colleague with some neuroendocrine staining or a case that came in for review or consultation, he really, he'll say it's divergent expression, stick to what you're calling it, and as in use the breast terminology and move on. I suspect there's going to be change in the definition of neuroendocrine tumors in breast in the next edition, because I think, well, I guess it needs to be a clinically, it needs to be a category of tumors that we can reliably diagnose and that have a particular prognostic or predictive implication. And other than small cell carcinoma type appearance, I'm not sure that we have that as yet. So yeah, if it looks neuroendocrine, I guess I'm fortunate enough to have an endocrine colleague who can give me his expert input, but just having immunohistochemical evidence of neuroendocrine markers doesn't make it, I guess, neuroendocrine tumor or neuroendocrine carcinoma. And I think the ones we do need to identify are the small cell carcinomas, because they may have different systemic therapeutic implications.
All right. If there are no further questions, thank you, Marilyn. And we'll move on to the next presentation by Dr. Rachel Han from Memorial Sloan-Kettering.
Hi, everyone. So I will just share my screen. And please let me know when you can see it. Oops. Okay. Okay, so hopefully you can see my screen. I'll quickly get started. So my name is Rachel. I finished my anatomical pathology residency training at U of T last year, and I am doing a one-year breast pathology fellowship here at MSK. So thank you for allowing me to present a case today. So this is a case of a 49-year-old woman who underwent a left lumpectomy of a lesion which was received on our personal consultation service. So we did not have any additionally provided clinical history. And so as you could probably tell from this low power image, this is an excision of a fibroepithelial tumor. So this tumor was characterized by areas of broad leaf-like architecture, and overall had a very well-defined border, no evidence of pushing or infiltrative stromal invasion. And though we didn't receive any images of the gross specimen, per their report, it was noted to be a very well circumscribed lesion grossly as well. The tumor showed moderate stromal cellularity, but what was most striking to us was the presence of marked stromal atypia. So on the higher power image on the right side here, you could see these incredibly large, giant, atypical, almost multinucleated stromal cells. And mitotic activity was also found to be mildly elevated at up to 6/10 high power fields in hotspot locations. However, the count was much lower in non-hotspot areas. And then strikingly, we found frequent atypical mitotic figures. So lots of tripolar mitoses, this one in the top middle, sort of an uneven distribution of chromosomes. So these were sort of scattered throughout the large atypical stromal cells as well. The lesion was also sent in consultation as there was a concern for a possible liposarcomatous element arising in the stromal cells. However, on our review, we believe that the fat actually resembled more so mature adipose tissue without evidence of atypia. And so we didn't think there were any liposarcomatous elements, either like a well-differentiated component or otherwise in the tumor. And so overall, given the unique findings of the tumor, including the striking cytologic atypia and the presence of abundant atypical mitotic figures, we pursued molecular testing of the tumor in the research setting, and this was an attempt to better classify the tumor. And so we did Sanger sequencing of MED12 exon 2 hotspot, and the tumor was found to be wild type for this hotspot mutation. And then in addition, we tried sequencing of the TERT promoter C228 and C250 hotspot loci for TERT promoter, and the tumor was found to be wild type for this as well. So based on the protocol for examining specimens from patients with Phyllodes tumor of the breast. Our tumor in question showed moderate stromal cellularity, marked atypia, no evidence of stromal overgrowth, a borderline or moderately elevated mitotic rate, however, a very well circumscribed border, and no evidence of malignant stromal elements, heterologous stromal elements. And therefore, we rendered the diagnosis in this case of at least borderline Phyllodes tumor. And the size was 41 millimeters, and it was completely excised. So I wanted to just go over Phyllodes tumor in brief. So these represent 2.5% of all fibroepithelial neoplasms, and they tend to present later than fibroadenomas, about 15 to 20 years later on average. Malignancy in Phyllodes tumor is frequently associated with overexpression of EGFR, c-KIT, and TP53. And studies have shown recurrent mutations in MED12. And this finding is more common actually in the benign to borderline Phyllodes tumor rather than the malignant. And this mutation can also be found in fibroadenomas. And this finding kind of supports the idea that some Phyllodes tumors arise from fibroadenoma. And this is also supported by the frequent finding of fibroadenoma-like areas in benign and borderline Phyllodes tumors. Now, there is also a subset of Phyllodes tumors that lack MED12 mutations, and some of these will have alterations in cancer-related genes such as TERT promoter, and the other ones listed in that bullet point there. And based on what is currently known, the finding of a TERT promoter mutation can help to favor the diagnosis of Phyllodes tumor over fibroadenoma. And in addition, the progression of benign Phyllodes tumor to borderline or malignant can show alterations in other cancer-related genes that we're familiar with, such as PIK3CA, RB1, TP53, and so on. So I just wanted to briefly highlight this recent study where authors evaluated the clinical and pathologic criteria of malignant Phyllodes tumors across different institutions. And in this study, they were evaluating different histopathologic features of Phyllodes tumor to more accurately predict metastatic behavior. So in this study, in their univariate analysis, only stromal atypia and stromal cellularity were associated with decreased metastasis-free survival. And in their multivariate regression analysis, they made a model that included cytologic atypia, stromal cellularity, and stromal overgrowth, which was able to successfully identify 71% of patients who went on to develop distant metastases within 5 years. So the positive predictive value of these three features together was similar to the 5 criteria that are currently proposed by the WHO to make the diagnosis of malignant Phyllodes tumor. However, the 5 criteria were only able to identify a subset of tumors that went on to have distant metastases. So there's an argument that the current criteria may be too stringent and may exclude the diagnosis of malignant Phyllodes tumor in patients that will go on to have metastasis. So based on those findings, the authors suggested a new diagnostic criteria list for malignant Phyllodes tumors that I've listed here at the bottom. Interestingly, the tumor that we had, our case, does not meet this criteria for diagnosis of malignant Phyllodes tumor either, because there was no evidence of stromal overgrowth or permeation of tumor borders. But I think it raised an important sort of discussion surrounding whether there needs to be a refinement in diagnosing malignant Phyllodes tumors, especially given that in that series that we just went over, many Phyllodes tumors that went on to metastasize were not captured in the malignant Phyllodes category by the current WHO criteria. And I think it also raises an interesting point about the role of molecular techniques in diagnosing and risk stratifying Phyllodes tumors. So I previously mentioned TERT promoter as being a marker that can help distinguish between fibroadenoma and Phyllodes tumors. However, I think the more clinically relevant question is how we can distinguish fibroepithelial lesions that will have no metastatic potential or very low metastatic potential, such as a fibroadenoma, benign Phyllodes, or even some borderline Phyllodes tumors versus those that will have metastatic potential. And TERT promoter actually has been shown to have increased expression in malignant versus borderline versus benign Phyllodes tumors. So this is by no means like a comprehensive overview of the molecular alterations in Phyllodes tumors, but I think it just shows that this marker and many other markers can soon be used in practice to help us classify these more difficult lesions. Thank you.
Thank you, Rachel, for this fascinating talk. So I actually have a question. So how is molecular tool used in the diagnosis of phylloides? Like, what do you do at MSK?
Yeah, so we don't do molecular testing routinely for Phyllodes tumors. So I think in this case, we went to sequencing just because there was a lot of diagnostic, I think, uncertainty or difficulty in this case. We definitely did not have all the features to call it malignant, but it was one of those cases where we had enough features that we were a little bit concerned, and so wanted to sort of support our concern by looking at something like TERT promoter mutation. This was done in sort of the research setting, so it's not something that we're doing routinely here. I think there is a suggestion that as I mentioned, it can be used, like TERT promoter mutation can be used for fibroadenoma versus Phyllodes, not really clinically in use for distinguishing between like benign, borderline, and malignant, but I think that's something that might be possible like down the road.
Thank you.
Rachel, that was great. Thank you. Can I ask, are you making the diagnosis of malignant phylloides in the absence of, you know, all the features being present, or how strict are you? I guess you might use that term, at least borderline, or like, will you just call something straight out malignant if they don't have all the features of malignancy? So in my experience here, it's only been like 6 months, but based on the cases we've come across that consensus, if a tumor doesn't have all 5 criteria or it doesn't have the malignant heterologous element criteria, I've seen the diagnosis like at least borderline, as we used in this case, used if we are concerned based on, you know, like marked stromal atypia or marked stromal cellularity. We convey that in the report to say that though like falling short of the diagnostic criteria, there are elements of this tumor that raise suspicion for early transformation to malignancy, for example. Okay, that's great. Yeah, I agree. I think we need to look at the current criteria. I think it's too stringent for what we include in the malignant category. So stuff to work on in the future. Thank you.
I also have a question, Rachel. It's a wonderful presentation. Do you ever or are you routinely using immunohistochemistry in this scenario of a suspected malignant phyllodes tumor? And what would be the panel?
So I don't think we have been doing routine immunohistochemistry. One thing that was actually done in our case at the referring institution was TP53. So they had stained it. It was interesting to see. I hadn't really seen it before. In our case, it showed sort of like a wild type pattern, or what I would call wild type in other tumors that have described wild type TP53 IHC. It's interesting because TP53, as mentioned, is one of the mutations that occur in the progression from benign, borderline to malignant. So I think, you know, that can potentially be used in the future once validated to mutational status, perhaps. We don't use it routinely. Ki-67 we also don't use routinely in our assessment of the cases. The only role that I've seen IHC use for these cases is if we're trying to distinguish it from, for example, metaplastic carcinoma or other sarcoma.
Thank you.
Thank you, Rachel.
Thanks.
I think there are no other questions, so we'll move on to Dr. Alan Yan from Memorial Sloan-Kettering too.
Let's see to share my screen. Thank you, Jessie. My name is Ellen. I also completed my anatomical pathology training residency at U of T, and I'm completing my one-year fellowship in breast pathology at MSK as well. And thank you for inviting me to present today. I have a personal consult case quite recently. This was Dr. Broji's case. We received this consult from outside institution of a 29-year-old lady from a right breast nodule by RES4. However, we do not have any other clinical information. Unfortunately, we do not have the size and how long and how fast it's been growing. And she's also status post ultrasound guided core biopsy that we have not also received. However, on low power, we can see that this resection specimen has this infiltrative papillary arrangement, looks biphasic from this low power. And there's more of an infiltrative border going into the fat as well. And you can see the spindle cell surrounding this papillary arrangement. And on closer look in medium and higher power, you can see that there's a biphasic proliferation of both the ductal epithelial component that's made up of columnar cells with moderate cytologic atypia, with occasional mitotic figures, and also a mild epithelial component that's focal spindle cell pattern in multiple layers surrounding this ductal epithelial component. The mitotic count was 7 in 10 high-power field. No necrosis was identified, and stromal reaction was seen ranging from inflammatory to focally desmoplastic changes. So our initial diagnosis or differential included adenomyoepithelioma and a papillary arrangement versus an intraductal papilloma with myoepithelial hyperplasia. And on immunohistochemistry, CK56 and CK7 highlight the epithelial proliferation quite nicely. And so did the calpone and P63. Again, the myoepithelial proliferation surrounding the ductal proliferation as well. However, no invasive carcinoma is identified. And this particular myoepithelial proliferation demonstrates ER positivity in 50 to 70% of nuclei. So just to touch base on the pathogenesis of adenomyoepithelioma, it can be broadly categorized into ER positive and versus ER negative groups. On the left, you can see that the ER positive group were initially described and published in 2013 that they would demonstrate mutually exclusive PIK3CA versus AKT1 mutation hotspots. However, also in recent years, by Dr. Pareja from MSK, they identified one case in 13 cases of adenomyoepithelioma that were ER positive to demonstrate the HMGA2 WIF1 fusion that were also mutually exclusive from the PIK3CA and AKT1 hotspot mutation. And this particular fusion was also previously described in salivary gland pleomorphic adenomas as well. And now moving on to the ER negative adenomyoepitheliomas, up to 60% of these cases from the study as a collaboration between the molecular pathology group and the breast pathology group at MSK, then identified the HRAS Q61 hotspot mutations, co-occurring with mutations also affecting the PIK3CA or PIK3R1 hotspots. In particular, the HRAS Q61 were also previously described in salivary gland EMCs, epithelial myoepithelial carcinomas in the salivary gland as well. And also recently from the MSK group, they were able to demonstrate that the RAS Q61R IHC had really good specificity and sensitivity in a small cohort of 26 cases. And also to highlight here that salivary gland-like tumors of the breast, other than actinic cell carcinoma as a controversial point, harbor the repertoire of somatic genetic mutations detected in their salivary gland counterparts. So the Ki67 for this particular case was relatively low. And however, on the right panel, you can see that we also performed the RAS Q61R IHC at MSK, and this case was negative, not surprisingly, because this case was ER positive. Of note, although positive RAS IHCs associated with triple negative invasive carcinoma, often including metaplastic carcinoma, squamous cell carcinoma variants, venous cell carcinoma variant, and matrix producing variants, and also low-grade adenosquame, carcinosarcoma, etc. A negative RAS IHC does not equate benign behavior. And in terms of prognostication, adenomyoepitheliomas are considered to be among the least aggressive breast neoplasms, generally cured by local excision alone. However, some can demonstrate unpredictable behavior. A spectrum of these lesions show that nodal metastasis has been reported, ranging from benign to atypical cases with no frank malignant histologic features. However, there are no current established criteria on how to categorize those lesions. In a recent study by Dr. Pariha from MSK, they also demonstrated that 5 out of 7 adenomyoepitheliomas with so-called infiltrative borders were positive for RAS IHC. However, that does not apply in this case, even though we did have infiltrative borders. There are several general features recommended for assessing these type of lesions, including mitotic activity, necrosis, cellular neoplasm, cellular pleomorphism, peripheral invasive borders, and overgrowth of myoepithelium. So in this case, we had slightly increased mitotic activity and peripheral invasive borders at least. So the final diagnosis rendered was a atypical adenomyoepithelioma with less than 1 millimeter to multiple inked margins. And these are my references. Thank you.
Well, thank you, Ellen, for your presentation. Yet another fairly uncommon entity. One I haven't really come across a whole lot in my practice. Does anyone have any questions? So I'm just going to quickly check the chat to see if there's anything there. Okay. All right. So if there are no questions, we'll move on to the next case. Thank you, Alan. So next we have Dr. Sonal Varma from Kingston General Hospital.
Hi, everyone.
Hi.
Excellent talk so far, so having fun with that. Here's my screen, so I'll follow Ellen's sort of direction, so to speak. This is a case of a 50-year-old woman who had a core biopsy. You can see my screen, right?
Yes, we can see your scan.
Awesome. So 50-year-old woman with 2 breast masses, and they were both BI-RADS 4. She gets 2 core biopsies, same breast. And so this is it's advancing. You're seeing everything, right? There's no issues.
Correct.
So she has one mass is indolent appearing lymphoma, and turns out it was marginal zone lymphoma, and then the second one, so the truly breast mass, was what we call complex sclerosing lesion with LCIS, and it was one of those ones where you have a bit of papillary sort of appearance, a bit of glandular appearance. It could be a radial scar going through a lot of hypoplasia and adenosis of different kinds, or it could be a papilloma with some adenosis and hypoplasia. So it was sort of in between. That's how we signed it out. She got the excision. Here's the excisional biopsy of the breast mass. And you can see it's not encapsulated. It has somewhat circumscribed border, but I'll show you other areas where it looked kind of like not circumscribed. There are some areas which give you a hint of maybe more sclerotic papillary cores like papilloma and being overrun by something, but then on other sides you do have lots of glandular proliferation. And I won't belabor this point because it's following Alan's presentation with sort of the same diagnosis. So here's another close-up of more glandular proliferation, lots of calcifications, But then
So now,
here,
sorry, can you put the presentation in the presentation mode so people will see just the presentation? It's difficult to see otherwise.
Okay, I will do that. I actually am seeing the slide share, but you're not. Sorry, let me stop sharing for a second. And I will share again. Are you seeing it as full screen now?
Yes, perfect. Thank you so much.
No worries. So here's that first picture that I was talking about with circumscribed borders and some papilloma type looking areas, and then lots of glandular proliferation on the other sides. Okay, and here's more close up. So you do see some solid areas, like, something's going on. You start wondering, could there be some atypical proliferation? But then there are other sites that are glands as well. Lots of calcification. So this had a mass and lots of calcification. Just a close up of that border. So here it's very circumscribed on the top with, you can see the glandular proliferation very easily. The second one shows the infiltrative interface with the fat. So I was worried that there may be something invasive going on here. Here's another close-up of the glands. And so you can see at this low power, maybe there's some clearing or not, but when you look at the higher power, there is definitely cytoplasmic clearing in a lot of these cells. So at this point, you start wondering about the papillary glandular sort of proliferation, biphasic, possibly adenomyoepithelioma would come to the mind. It would be the first one to come to the mind. And now here's myosin, and you can see a lot of myoepithelial staining around each individual gland, and same with P63, same thing going on here. Very kind of balanced proliferation going on. Now going to those solid areas, here's your typical, biphase or biliary glands here, but then in these areas, it looks like there's a lot of proliferation, and it's low-grade proliferation going on. I was worried, is there something invasive in between, or is it all nested within what was originally glands? And turns out everything was nested within. Here's a closer view of those, and here you can appreciate that it looks like there could be a lobular neoplasia going on. Here's another close-up view, so you can see those glands. So there are some background glands here, that the original ones, and then some that are completely filled up by cells. There are occasional mitotic figures, but not heavily mitotic. Cells are still, they have tiny nucleoli, but I won't go as far as pleomorphic LCIS on this one. So did E-Kettering, and here's your E-Kettering. So all the residual or all the glands are positive for E-Kettering, myoepithelial and epithelial. But then in the center, you see that there's loss of E-Kettering in keeping with morphologic impression of LCIS. Now that infiltrative looking area, here's a myosin on that area, and turns out all of those little nests still have preserved myoepithelial staining, so I did not go as far as invasive. And then in the center of the lesion, where I was thinking there could be invasion, same thing, it was all well preserved myoepithelial cell layer. This one was ER positive to about, again, about 80 to 90 or 70 to 80 at least. The trouble was that LCIS areas were picking up more ER than other areas, but this is one focus where the glands are really positive as well. Here's the PR. PR was patchy, and here's the LCIS areas which were picking up more, and the glands were picking up rare, the normal breast kind of morphology or phenotype for PR. So that's the end of my presentation, and I called it adenomyoepithelioma with LCIS. And it was at the margins, but I don't think it matters because of LCIS. So because of adenomyoepithelioma itself, they were not too keen on re-excising or anything. And then LCIS, just normal classical LCIS, doesn't make it a re-excising tumor. So that's it.
All right, thank you, Sona. It's a great follow-up to Ellen's presentation. It's,
yeah, and it saves me talking about all the molecular stuff as well. So as I was going through her talk, I just pared my tongue down. So.
Oh, what a great coincidence.
Are there any questions? Doesn't seem like there's anything on chat.
I don't mind to ask a question. Sonal, was there any adjuvant therapy prescribed or considered?
No, and probably, it muddies the water because she does have a primary breast lymphoma. So, she's going to go for treatment regarding that. But from adenomyoepithelioma, nothing, no adjuvant therapy was considered at the tumor board. We discussed it at length at the MCC.
Thank you.
Okay. Any other questions or remarks? All right. Well, if not, I think we'll end this meeting a little bit earlier than anticipated. Thank you so much, everyone, for participating. We got to see really, really interesting and fairly rare entities. Sorry, Anna Marie, you wanted to say something?
Sorry, Jessie, didn't mean to interrupt. I just wanted to, if I could take the opportunity to get a plug in. We are UHN advertising for a breast pathologist. If anybody is so inclined to join our great group of breast pathologists here. It's an extra, it's a new post, not replacing one of us. So just wanted to bring your attention to that, and maybe some of you would consider at least looking into the position. It's a great group of breast pathologists that we have here. We are going digital next April, which should allow more flexibility. So, it's an exciting opportunity if anyone would like to consider it. So sorry for taking advantage and butting in there, Jessie, but just wanted to get it out there. And thank you very much.
Well, thank you, everyone. Anna, did you have something that you wanted to say?
Yes, I would like to thank everybody for amazing presentations, to Anna Marie and Sharon for great remarks, and thank you for supporting this community of interest throughout the year. There are holidays coming, so everybody, happy holidays, happy new year. Have amazing time with your families and loved ones. And just a reminder, please take seriously and complete CPD evaluations that we're looking forward to receive your feedback. And once we receive them within 4 to 5 weeks, you'll receive a CME certificate for this meeting just before the time for Royal College deadline. Thank you, Jessie, of course, for organizing this amazing event.
Well, you're welcome. Thank you, everyone.
Bye.
Bye.
Thank you. Bye-bye.